Good evening, folks. My name is Dr. Daniel Alterman. I'm a vascular surgeon locally. Purpose of tonight is to kind of give a little whirlwind tour of some venous topics that are frequently queried in our clinic. Vascular surgeons get called to evaluate a variety of venous conditions. These are things as diverse as venous thromboembolic disease and the consequences of chronic venous insufficiency. Many of these conditions are related to chronic disability, and some of them we see and fix in the office, other more acute conditions in the inpatient setting. One of the themes of this brief talk is to review conditions that we're frequently asked to evaluate, and also it's important to pay attention to the decision-making process. Many of the decisions that we have to make for advanced venous disease are similar in terms of risk stratification and weighing the risk-benefit ratio. These are things as diverse as extensive iliofemoral DVT with a May-Thurner syndrome, advanced phlegmasia with a Paget-Schroeder, or even the more severe manifestations of pulmonary embolism. The other end of the spectrum, we deal with the consequences of varicose vein disease and chronic venous insufficiency. These conditions, while they're thought of to be minor, can have pretty substantial morbidity, including painful varicose veins, edema, and venous ulcers. When the residents rotate with us, I tend to encourage them to look at the American College of Chest Physicians guidelines. The latest iteration, AT10, covers in bullet format a lot of the frequent questions that we get. There are some other consensus guidelines which we compare these with. The most important ones are from the Society of Vascular Surgery and the American Venous Forum. The European guidelines made a nice review of treatment guidelines for pulmonary embolism, both in outpatient as well. One of the reasons the guidelines are difficult to interpret is that the endpoints for venous disease is often soft. When you're dealing with a heterogeneous population with outcomes that are largely related to lifestyle impact, it makes it difficult to make a randomized trial, and that's why I think some of the guidelines are a little bit difficult to interpret, particularly when you look at them for the first time. To begin, let's think about a patient that has a catheter-associated thrombosis. This is not an infrequent inpatient call we get. If we consider a 55-year-old woman that needs 6 weeks of IV antibiotics for osteomyelitis, what happens when she develops pain and swelling on her 4th week of treatment? Typically, this is evaluated with a venous ultrasound. One scenario would be just a superficial catheter-associated thrombosis. The literature would support removing the catheter if you don't need it, but there are some other treatment options based on local expertise and patient-specific circumstances. Some options would include rotating the catheter to the other arm, starting typical treatment for phlebitis. Those are things like NSAIDs, warm compresses, or even just continuing the catheter and treating them with anticoagulation. The level 1 evidence does suggest that we remove the catheter if it's not needed. There are some other situations which become a little trickier. What if the patient has had a mastectomy and can't have a catheter in the other arm? In those situations, I tend to encourage keeping the catheter, particularly if they only need it for a few more weeks. Even if it has an associated DVT, you can still keep the catheter, use it if it's functional, treat with anticoagulation, and then continue their current course when it's completed. If the catheter is not working poorly, you can give a small dose of TPA through it. The situation becomes a little bit trickier when patients have more advanced thrombosis or even phlegmasia. With a true DVT or an axillary subclavian thrombosis with the catheter, it's preferable to remove it since it's the obvious provoking cause. We do have the option of treating with anticoagulation and continuing it, particularly if the patient has difficulty with alternative access and say they only need the catheter for another week or two. Occasionally, we're asked which patients may need more advanced therapies such as clot debulking or TPA. Patients that generally need that have more severe skin manifestations or signs of phlegmasia. But for most patients, 3 months of anticoagulation is indicated. Occasionally, the patients also have concurrent GI issues, especially if this is a polytrauma and their osteomyelitis was related to an accident. In general, if the patient is not having active bleeding, they probably don't have an absolute contraindication. In a patient that's had recent GI bleeding and an upper extremity DVT, the risk of pulmonary embolism is actually small. On an inpatient side, what I typically recommend is a low-intensity anticoagulation. You can often titrate heparin with a subtherapeutic PTT for a day, and if there's no bleeding, you can advance. One of the things I try to encourage residents to do is just discuss with the person who diagnosed it if they had recent endoscopy, find out what their actual risk of bleeding is. Many of these patients will actually tolerate an intermediate intensity and they can be advanced. Occasionally, we're called because someone thinks the patient needs an IVC filter since they have a contraindication. In general, in the superior vena cava position, that's not indicated, and there's a lot of contraindications that can occur. The literature is full of case reports where patients have perforations of the superior vena cava from supposed SVC filters, and in general, we recommend against these. If someone has more extensive swelling, basically they have a painful, swollen blue hand, those are patients that usually need to be considered for some sort of intervention based on local expertise or experience. Often interventional radiologists or vascular surgeons participate in their care. There can be substantial morbidity, what's referred to as post-thrombotic syndrome, if you just put these patients on Coumadin or Eliquis. Oftentimes we can both preserve their access and do some sort of local treatment through their access to fix it, in addition to anticoagulation, depending on their underlying risk factors. Whether it's an upper extremity extensive DVT or lower extremity or even a large submassive pulmonary embolism, the treatment options and considerations for more advanced treatments or clot debulking are often same with a similar therapeutic index. What we tend to look at for most patients is anticoagulation with consideration of clot debulking. The literature actually does not support this, and there's grade 2C recommendations from CHEST that talk about just anticoagulation over thrombolysis being preferred for upper extremity DVT. They do give the caveat, though, saying that if a patient places a high value on their upper limb function and the risk of post-thrombotic syndrome, to consider TPA treatment. Most of our patients who are younger and active are obviously going to place a high value on the chronic limb morbidity, and that's why we offer these treatments, particularly if your patients have it's their dominant hand and they have a painful swollen arm. The lower right-hand field shows an example of an acute axillary subclavian DVT. In this situation, it would even be feasible to preserve their PICC access. We could do a single stage treatment with either power pulse and giving TPA through the existing catheter to break up their DVT and then continue their anticoagulation afterwards. The considerations for TPA are really the same, whether it's upper extremity, lower extremity, or pulmonary embolism. About 2 to 3% of patients with higher doses will have serious complications, and that's why it needs to be considered judiciously. The risks are actually related to the age and the higher doses. In general, if you're over the age of 75 and are getting more than 50 milligrams, you have about a 2 to 3% risk of intracranial hemorrhage and up to a 10% risk of internal bleeding. With lesser doses, the kind we use for catheter-associated thrombosis or even just a small dose through the catheter itself, the risk is much lower, and usually that tips the favor in odds of treatment, particularly when we're talking about disability. Obviously, absolute contraindications are things like pregnancy or recent stroke or eye surgery. The same considerations apply to swollen legs. Patients who have iliofemoral DVT often come to our attention acutely, particularly if they have significant pain and venous claudication. With a single episode, there can be substantial long-term morbidity, and many of these patients need to be considered for some sort of adjunctive treatment. With more advanced disease, the patients are hospitalized. Whether you have a painful swollen blue leg or just a pain, the symptoms can actually be very similar, although the frank phlegmasia is a little bit more dramatic. Treatment options up front include various kinds of anticoagulation. What I tend to tell the ER docs when they call us is that if there's a thought they may need some sort of intervention, just start them off on heparin first, because you can titrate it around the time of an invasive treatment, and usually it's easier to interface with some sort of TPA therapy. Other options on the table include the novel oral anticoagulants, things like Eliquis and Xarelto. The literature supports a lower risk of bleeding with these, and this is largely from the cardiology literature, but in general, those have been more preferred over the vitamin K antagonists. The literature, the guidelines also talk about low molecular weight heparins as being the preferred agent for cancer-associated thrombosis. This isn't because low molecular weight heparins work better with cancer. It's really because of logistic concerns. If a patient is nauseous from their chemotherapy, they're often going to have easier access and not have to interrupt their treatment or miss doses of their Coumadin or Xarelto. Beyond anticoagulation, a hypercoagulable workup often needs to be considered. What I try to do when I triage these patients in an inpatient or ER setting is to get their hypercoagulable labs up front before they get their first dose of heparin, because many of them may even need to be considered for lifelong anticoagulation. Beyond that, then we screen the patients for more advanced treatments like thrombectomy or TPA treatment, with the goal that we're not only relieving their acute symptoms, but preventing post-thrombotic syndrome. This is an example of a large iliofemoral DVT. These patients often have substantial venous claudication and pain. Many of them get better with even 12 hours of a power pulse treatment or some sort of catheter-directed TPA. The typical hospitalization course is about 24 to 48 hours, and then we look for some sort of underlying lesion. Do they have an iliac vein compression, a May-Thurner syndrome, or some sort of hypercoagulable state? When we get these patients open, they feel immediately better and then start them often on a novel oral anticoagulant. If they have an underlying May-Thurner syndrome, we usually evaluate that with intravascular ultrasound. On the chronic side of things, there are patients that come to our clinic that have had years of swelling, and they've often been told that compression and anticoagulation is all that can be offered to them, but they can have substantial morbidity. This is an example of a young woman that was evaluated 2 years after an iliofemoral DVT. She's been compliant with her anticoagulation, and she's got a fair amount of disability. She can't work, and the stockings are painful. Well, what do we do for this patient? On venogram, we're going to find an underlying iliac vein compression. Oftentimes, we can treat these, sometimes as outpatients, and the patients get better. They can have substantial relief of their disability and get their quality of life back. Most of these patients end up needing long-term anticoagulation and monitoring, and they do have risk of recurrence, but we screen them and follow their stents after if they end up getting treated that way. On the other side of the spectrum, we get a lot of questions about smaller DVTs, what to do about tibial thrombosis. The literature kind of hedges on what to do for smaller DVTs, particularly since their risk of propagation is not as high and there's not as much symptoms with them. I tend to be conservative with tibial DVTs, particularly if there's a lot of pain and swelling associated with it. If it's provoked, most patients need 3 months of anticoagulation, and that's probably the standard of care. If the patient is concerned about risk factors from anticoagulation or has contraindications for anticoagulation, those are patients that can be treated with serial observation, aspirin or compression with symptomatic type treatment. Probably about 15% of them will end up propagating, and if they do, they can always be converted for anticoagulation. It would be very unusual to place a filter for a tibial DVT, and that's almost never indicated. We get lots of calls about pulmonary embolism treatment. There's actually fairly robust guidelines for the intermediate or low-risk DVTs. Many of these patients can be treated as outpatients, but the sicker patients, particularly those that have shock or severe cardiopulmonary compromise, often end up hospitalized. Some of the frequent questions we get about pulmonary embolisms include, does the patient need an IVC filter? What's the duration or intensity of anticoagulation? And who needs some sort of clot removal treatment? A lot of those decisions are based on understanding what your local expertise is and what your resources are. Anticoagulation remains the standard of care, but there are plenty of patients that do benefit from consideration of clot removal. More advanced supportive care and revascularization is needed, oftentimes for patients in shock, and these are adjunctive treatments like thrombectomy, TPA, or even ECMO. Years ago, it was thought that many patients need filters after high-risk surgery, bariatric surgery, or trauma. The literature has now really fallen out of favor that routine filters in general are not needed. What I try to emphasize when discussing these dynamics, either with a multidisciplinary team or the residents, is that PE is still a deadly disease. The combined mortality of pulmonary embolism is actually more than HIV, breast cancer, and motor vehicle collisions combined in the U.S. Some estimates say as high as 300,000. I think it's more like 150,000, but it still is a substantial disease burden. The underlying physiology is often related to obstructive shock. There's a VQ mismatch and an ischemia that occurs to the right ventricle. This causes a progressive shock and ultimately a spiral towards compromise. Patients that have that oftentimes are treated in a multidisciplinary fashion. Oftentimes they trigger the same kind of response as to a STEMI or multi-trauma patient. Filter patients oftentimes are considered if they have a contraindication for anticoagulation. There is a thought that filters will prevent pulmonary embolisms, and this is a misconception. There was actually a randomized trial, the PRECIP-2 trial, which showed that filters don't reduce the risk of recurrent pulmonary embolism. You can actually throw clots either around or through the filter, and they don't necessarily prevent them. They're really designed to prevent the large ones that are going to kill you. More clear indications include a patient who's had a recent thromboembolic event and has a contraindication for anticoagulation. There are situations where that can be modified, particularly if they're several months out, but usually we decide these on a case-by-case basis. I think the more clear indications are a high-risk patient that needs a high-risk procedure. Several weeks ago, I saw a patient that had multiple pulmonary embolisms, was homozygous for factor V Leiden, and needed orthopedic surgery. Well, obviously, this patient is at a high risk. In these situations, we place what we refer to as a bridge filter. Oftentimes, the filter can be placed a week or two pre-op and then take it out several weeks post-op when they're on their anticoagulation. The placement and removal often doesn't require interruption of their anticoagulation, so it doesn't affect their lifestyle much and doesn't keep them in the hospital for weeks on a heparin bridge. There's a whole laundry list of so-called soft indications for IVC filters, and we generally evaluate these on a case-by-case basis. These are things like free-floating iliofemoral DVTs, or a patient who's poorly compliant with anticoagulation, or someone who's had a complication from it. In terms of deciding who needs more advanced treatment for pulmonary embolism, we generally do this by risk stratifying the patients. The most common tool used is something referred to as the Pulmonary Embolism Severity Score, or PESI score. This looks at factors like the patient's age, history of cancer, and how much it impacts their physiology. In general, older patients that have a higher clot burden, they're hypotensive, have shortness of breath, or history of cancer, have up to a 10 to 20% risk of dying of their pulmonary embolism. The risk stratification is really not based on their volume of clot, so looking at their underlying risk factors is very important when deciding how to treat them. What I tend to tell the residents is that Ps come in 3 flavors: low, intermediate, and high risk, and we base this really on the risk stratification, not necessarily by eyeballing the CAT scan and deciding who has the most clot. The PESI score looks at the physiology and patient risk factors. The higher risk strata can have up to a 20% risk of mortality. Some institutions have nowadays what they refer to as PERT teams. It's sort of like a code PE where there's a multidisciplinary either teleconference or even if people are in-house to discuss the patient, since there's a variety of treatments that are being done for PEs beyond just supportive care and anticoagulation. The European guidelines have a nice algorithm to really help guide this. The current literature supports a brief hospitalization or even outpatient treatment for low-risk pulmonary embolism. When a patient is severely compromised and in shock, well, they need more advanced treatments. And in addition to airway support, anticoagulation, and volume loading, some sort of clot removal usually needs to be considered. These are things like pulmonary embolectomy, catheter-based treatments, or TPA. Recognizing the risk of TPA and risks and benefits, sometimes this modifies it. We've actually developed a nice local experience with catheter-based treatments for pulmonary embolism. In the last year, our team has treated about 5 massive and submassive Ps, catheter-based, and we've had good success. Some of these patients have even gone home in 2 days on oral anticoagulation. Obviously, we don't want to give TPA to a patient that is thought to be at high risk. The current literature actually supports systemic anticoagulation over catheter-based treatments based on really the risk-benefit ratio. but it hedges based on the patient's risk factors, and I think it needs to be decided more on local experience rather than from the guidelines. Probably the most challenging group of patients that we see are the patients with the so-called submassive pulmonary embolisms. These are patients who have severe compromise, chest pain, a large clot burden, positive troponins, and signs of right heart strain, but their vital signs are stable. The current literature would support they don't need anything beyond heparin, but some of these patients will decompensate. There's still a lot of controversy in the literature about what to do with severe symptomatic submassive PEs. I tend to evaluate these on a case-by-case basis with a preference towards some sort of clot debulking for appropriate candidates. The device that we're currently using to try to debulk these is from the Inari company. Essentially, it's a transfemoral approach. We can go into each subsegmental lobe and essentially suck out the clot. Most of these cases take about 30 to 40 minutes, and they're about as risky as any peripheral procedure. The current guidelines would support peripheral thrombolysis over catheter-based means, but a lot of it depends on institutional support. One of the reasons that this is controversial in the literature is that you have this whole slew of soft outcomes that it's hard to define with a randomized controlled trial, particularly if you're looking at late outcomes with right heart pressures and pulmonary morbidity. In a subset of patients that already has comorbidities, those can be hard to define. In general, in younger patients where it's going to cause more long-term impact, my preference is to screen them aggressively for some sort of clot removal because many of them are going to have long-term morbidity. Even patients that end up with chronic pulmonary hypertension, they can end up being pulmonary cripples if you leave their clot in there. On the other end of the spectrum is milder disease, but still a disease that causes a lot of morbidity. This is chronic venous insufficiency. We see lots of patients in the office that have severe varicose veins and more advanced findings like chronic edema and even ulceration. These are clinically classified by something referred to as the SEEP classification. On the mild end of the spectrum, it's just varicose veins. More advanced disease is venous ulcers, painful edema, and post-thrombotic syndrome. Many people tend to think of these as just vein problems, but they can cause substantial morbidity, sometimes even leading to disability. We tend to screen and treat venous ulcers aggressively because every time you have a venous ulcer, you have about a 50% chance of it recurring, and it needs to be treated. Oftentimes, we can get these patients healed, and with subsequent attacks, though, usually they have a slower healing. Occasionally, we're called to see patients that have thrombophlebitis. So most of these patients do not need intervention, usually just screening for an underlying DVT, which can be present in 10% of patients, is all that's needed. I see lots of patients that are triaged as an infectious complication. Most of them don't need antibiotics. The only exception is if a patient has some sort of injection history or IV drug abuse. Those are patients that can get pretty sick. Probably about once a year we'll see a heroin addict that has an upper extremity phlebitis, and usually this is a suppurative thrombophlebitis. Those are patients that get very ill. Usually they need inpatient treatment with either a venectomy and need to be screened for endocarditis. The outpatient treatment a lot of times involves recommendation for compression stockings. There's really only grade 1 evidence for healing of ulcer with compression stockings. Most vein patients don't need lifelong compression stockings, although it's often used. Compression stockings have actually been used for thousands of years. This is why the Romans used these gaiter-type compressions so they wouldn't get their venous claudication on their long marches. Adequate compression, usually 30 to 40, helps heal venous ulcers. Oftentimes, patients with venous ulcers need treatment of their underlying venous insufficiency as well. The way we assess that is with a venous ultrasound. A couple times a month, we'll see patients who have fairly advanced vein disease, and they'll say, listen, I know I've got bad veins, but my venous ultrasound is normal, so what's the truth? And do I actually have vein disease? Usually what they're referring to is they've had a venous ultrasound that essentially just rules out a DVT. It's not looking at venous insufficiency. So if you're concerned about underlying venous reflux or severe vein disease, you have to order a venous insufficiency study. This looks at factors such as valve closure time with a Valsalva maneuver, and that can often point towards a diagnosis of chronic venous insufficiency and can help narrow the diagnosis for a non-healing leg ulcer. And the differential diagnosis can be fairly broad. A typical patient we see is a patient that's had incidental trauma, a non-healing wound for several months. They've had topical antibiotics, and it's just not healing. Like most things in medicine, the clinical history and appearance will give the diagnosis. In the differential diagnosis is diabetic ulcers. These are typically in a neuropathic area on the plantar surface. Usually there's heaped up skin edges. If we see a patient from a nursing home that's got redness of the heels and some sort of immobility, usually this is related to pressure ulceration. If there's heaped up skin edges or discoloration, many of these patients need a biopsy to rule out malignancy. If the patient has typical atherosclerotic risk factors and absent pulses, this points to a diagnosis of arterial ulcers. Those are probably the most common differential diagnoses that we're able to resolve in the clinic. More advanced findings like rheumatoid ulcers or calciphylaxis are usually pointed by the diagnosis. Once we have a diagnosis of venous reflux, typically the answer is to treat with compression, reduce the bioburden. There's no evidence that says one form of compression is better than another. For years, patients were saddled with Una boots. I tend to use Silvadene, Telfagauze, and compression. That, combined with treating their reflux, often gets them healed. There's been randomized controlled trials with compression, but there's really not one that's better than the other. There is level 2 evidence that says patients who have active venous ulcers and reflux, their reflux should be treated. The days of venous stripping is really antiquated. Nowadays, most of these are treated with percutaneous treatments in the office. The modern workhorse for this is the saphenous ablation. For medial ulcers, typically the underlying cause is going to be a refluxing greater saphenous vein. When the ulcers or wounds are on the lateral calf, usually that's related to the lesser saphenous vein. If there's a refluxing perforating vein or underlying varicose vein, usually we can treat those percutaneously with some combination of sclerotherapy or even an ambulatory phlebectomy. Oftentimes the healing is pretty rapid. Patients that have had antibiotics and compression or Una boots for months, when we treat their saphenous vein, particularly if it's been chronic, usually within about 2 months we can get them healed. Some patients I've even had heal within 6 weeks, and they think you're some kind of miracle worker, but they have a diagnosis of venous insufficiency, and those are things oftentimes we can evaluate and treat. The success rate with saphenous ablation is high. The 10-year closure rate is often more than 90% with initial technical success of close to 100%. Our DVT experience or complication has been less than 1%. If they have a small associated E-hit or catheter-associated thrombosis, oftentimes that can be observed or treated with aspirin and a repeat ultrasound in a week. It's rare that patients need anticoagulation. If they're on anticoagulation for their atrial fibrillation or previous DVT, you don't have to stop it. You can treat the ablation with it, and they usually close fine. This is typically done with a percutaneous Seldinger technique, accessing in the mid-calf. We try not to access it too low to avoid injury to their saphenous nerve. If patients have a saphenous nerve injury, they're very frustrated, and there's really not much that can be done to fix it. Most patients are very comfortable with a little tumescence. Usually moderate sedation or deep sedation is not needed, and the outcomes are usually very good. Thanks for your time, guys. I'll take any questions.